I would like to welcome him. He been in Kuwait this year for 2 times, and there the people there are highly appreciating, and he is a good teacher. And I can say that they told me, okay, I can see it myself, the cute tabur without questions after his lectures, to take use from his information was the longest that happens in any meeting in Kuwait. And everyone was asking, and they would like to learn from him. And he's a very good teacher, and he's a very good researcher actually. Dr. Medhat is going to present his paper about added value of specticity in nuclear medicine. Shabbat.
شكرا دكتور. Thank you so much for your kind introduction. بس عايز ابدا اقول انه انا قابلت الدكتور عبد الرزاق اول مره سمعت عنه قبل ما اقابله، لانه كنت عايش في جمهوريه اسيوط، فما عنديش فكره اللي بيحصل في القاهره ايه. طلعت من اسيوط مباشره لهوبكنز، فلما رحت هناك دكتور رايتنر قال لي انت عندكم واحد في مصر اسمه دكتور عبد الرزاق. كنت مكسوف ان انا مش عارف مين الدكتور عبد الرزاق، فبأول زياره لمصر رحت زرته في مستشفى المقاولين في وقتها. فربنا يرحمه ويجعل اعماله في ميزان حسناته ان شاء الله. وبنذكر بالخير برضه الدكتور الجزار والدكتور عبد الدايم، الاثنين اساتذه فاضل، نحسبهم على خير وندعو لهم بالشفاء. الاثنين بيمروا بعكة صحية. When I start by, do I need to use the microphone ولا ممكن نغيره؟ كده سامعني اللي ورا؟ I want to start by thanking Dr. Adil Dr. Husna and the rest of the organizing community, Dr. Khalid Ta'ala, for inviting me, and I'll be happy to come here anytime there is any invitation from us. That's the least that I can do, and I can speak on behalf of many of us who are living in the U.S. now, that we're very proud of what's going on in Egypt, and we all feel indebted to try to help in any way, shape, or form that we can. So the least that we can do is show up whenever there's a need to contribute in anything, even though it's a small way. So what I was asked to talk to you about today is the added value of SPECT-CT in nuclear medicine. I'll try to keep it an hour, but I'll be here till Saturday if there's any questions or discussions. I'm following the legal system in the U.S., so we have to put a disclosure that I'm a meeting participant and lecturer for Philips Medical System. Just starting from PET, and we'll build to SPECT-CT. This is relatively recent, just tallying the distribution of indications for studies in PET world. As you can see, that we do more oncology than cardiology or neurology, although cardiology and neurology is starting to pick up some steam, and I think they will continue to play a larger role than they ever did in the past. If you look by number of scanners, you'll see that about 50% of the scanners in the US is surprisingly about mobile PETs, CT and PET scanners, which is something that's not very common in Egypt or in the Middle East. And I think that needs to be explored, especially in areas where they don't have access to big centers. So the mobile PET can move from one place to another and provide a very decent service that's comparable to the fixed sites. This is the largest study ever published in the nuclear medicine literature regarding the added value of PET-CT and PET in oncology, and bottom line is that PET changed management in about 38% of patients undergoing PET scanning. So you would think that because of the success of PET-CT, SPECT-CT should not be far behind, and it should be expected that SPECT-CT will have the same kind of success story, but we're still struggling in the US and in the rest of the world to try to make a case for SPECT-CT as much as we made a case for PET-CT. Keep in mind that they both started about the same time. When I was at Hopkins in 2001, at that time, it was kind of the first SPECT CT scanner and the first PET CT scanner that was available in the state. But PET CT took off and SPECT CT died, and then there was revival of SPECT CT in 2004. Philips came up with a scanner, and Siemens came up with a scanner, and GE had already some scanners in the market. Nonetheless, SPECT CT struggled, and let's go over why. Cost is a problem. In the US, not just recently, but over the last few years, the government has been cutting payment for imaging. Nuclear medicine is no exception to that. So why would you buy a scanner that's not going to make you more money, because you still collect the same dollar amounts that you collect from a study that's a SPECT scanner. Space, because SPECT CT scanners are typically larger than SPECT scanners, and most of the hospitals are old, and sometimes the reconstruction of a room may cost just as much as the scanner itself in the US. Radiation exposure is becoming a major issue worldwide, so now we're adding to the radiation dose from the SPECT side of things, additional radiation dose from the CT part of the SPECT CT. Then there is the CT-related artifacts, such as truncation artifacts and metal-induced artifacts. These are the issues that we as nuclear medicine physicians need to be very aware of, otherwise the whole field will be taken over by radiologists if we don't know enough about it. But nonetheless, it's introducing new artifacts that our eyes are not used to in the SPECT world, which also leads to misregistration, because you're doing the CT and the SPECT CT not simultaneously but sequentially, and as a result of that you can have issues regarding misregistration and misfusion artifacts. Then you get into the issue of training and credentialing, whether it's for the physician side of things or the technology side of things. In the US, the technology side of things is actually more advanced than the physician side of things in getting technologists ready to handle CT parts of the SPECT and the PET than the physician side of things. Workflow and scheduling. Most of us, we have one PET CT scanner, we have multiple gamma cameras. So there's always a challenge of who's going to make a decision of whether this patient should have a SPECT CT or a SPECT only. And in the PET CT world, when you do CT for attenuation correction, you end up by shaving off about 40% of the image acquisition. But in the SPECT CT world, when you change the patient from a SPECT to SPECT CT, you're not saving any time. In fact, it's taking longer to do the study than if you do dedicated SPECT. So it's not quite the same if you compare it to PET CT. Now, in nuclear medicine, there's always a question of how do you balance this difficult equation? How can you get the best image quality that you can without increasing the dose or cutting the dose because you want to expose the patient to less radiation dose, and how to cut the time? And the problem is whenever you optimize a parameter, that will lead to deterioration in others. So if you improve image quality, then you either have to inject more or you scan longer. So it's very difficult if you decrease the dose, then you either have to compensate for it by scanning time or compromise the image quality. If you cut the scan time, then you either have to inject more or degrade the image quality. So there's always this challenge. And clinicians prioritize things differently based on the patient and based on the need for that particular study. So if it's a pediatric case, you may be more sensitive to the issue of the dose. But then also if it's an obese patient, then you may be compensating for it by imaging longer or injecting more or a combination of both, and you may still have deterioration in the image quality. This is a study in the PET world, but still applicable to the SPECT world, where the issue of obesity is becoming a major challenge in the whole world and in imaging in general, and more importantly in nuclear medicine. So the bottom line of the studies that showed that the instance and prevalence of obesity among patients undergoing PET scanning is actually more than the national instance, which is surprising because when we did the study, we thought that these patients primarily have cancer, so they will be kind of skinny, losing weight kind of patients from the cancer, but actually turned out to be the opposite, which makes sense because some of these patients may be obesity, we know, predisposed to some types of cancer, so maybe that is part of the problem. So this was the conclusion that obesity was actually higher than the national average. It was 45% in our patient population, and the national average is 30%. Now, this is an interesting slide that for the U.S., Missouri is kind of Midwest. Most of us are familiar with New York, kind of East Coast, and California, West Coast. Midwest is somewhere here, where Chicago and St. Louis is. Just keep in mind while we look at this slide that light colors, light blue is good because that means less than 10% or 10 to 14%. Red is bad because it means that you have a much higher obesity. And if you look at what happened between 1985 till 2008, if I recall, and you see what's happening now, and you see how much we changed, becoming bigger and bigger, more and more obese. And that's affecting multiple things in the U.S., from the size and the weight capacity of the bed that people should be using at hospitals, to the size of the wheelchair and the weight capacity of that wheelchair, to the imaging cameras, to the bed of the camera, to the injected dose. So everyone is pushing for higher size patients, but unfortunately that's at the expense of a radiation dose, which continues to increase. This is a recently published data showing that between 1980-82 until 2006, we pretty much have multiplied the radiation dose for medical exposure by about 600%, from 0.5 millisievert to 3 millisievert now. And you can see that nuclear medicine is a small sliver of that, and most of it is because of the natural background. But nonetheless, the natural background was the main source back in the 80s, but now medical exposure is significantly higher than what it used to be, and certainly CT is the main source of radiation because of the number of CT studies. It's something that both Europe and the US is very concerned about. The Joint Commission is a governing body in the US that kind of guides guidelines, and now they are pushing for recommendations. Okay, that's what they call it at the beginning, and suggestions about how to cut the radiation dose by using the right dose, the right test, the effective processes, safe technology, safety culture. Basically, they are asking medical institutions and imaging centers to go through the whole process from A to Z and come up with a plan of how to decrease the radiation dose. This is how it works in the U.S. It always starts with some guidelines, recommendations, making it sound nice and polite, but it's a matter of a year or two, and that will be the law of the land, and they will control the payments and threaten that you're not going to get paid if your radiation dose will expose this level, and you are becoming legally liable. So this is a big, huge business, and all vendors now, the Siemens, the GE, the Philips of the world, are seeing that writing on the wall, and they're starting cutting radiation dose as much as possible. When I go back to St. Louis in April, we're going to have an update in our PET-CT scanner that will result in increasing the radiation dose from the CT part of the PET-CT by 50%. That's because all vendors are becoming sensitive to that issue. Now, why do we need SPECT-CT? Do you really need, and when we started with PET-CT, people would look at the PET-CT studies and say, I don't really need it. With good eyes, you would not need the CT. That's, of course, now becoming the standard of care to do things with PET-CT, and that argument is no longer an argument, but it is still there in the SPECT-CT world, where some people are saying it's taking longer time, it's high radiation dose, issues with throughput, issues of cost, all of that, and they're making a case of, do you really need it? And the answer is yes. So I'll show you our experience before we had the SPECT-CT, then how that experience changed with having a SPECT-CT. So if you look at this study, which is an MIBG scan for a child that had posterior mediastinal neuroblastoma, had dissection back in 2008, and then it had recurrence a few months later, which these are posterior views. So this is in the left chest, posterior chest, and then had a follow-up study in January of 2009. And you can see that there's some activity in the posterior chest here that in the planar images it will be difficult. So we get the CT, which is done in a separate institution at a different time point, and hold the report, not release it till we get the CT, do the image fusion using a software, in this case is Vista. Then we come up that this is truly activity which is in the SPECT. You see a black dot, you don't know where it is, but then when you fuse it with the CT, it is truly in the posterior mediastinum, paraspinal, and this is the study that in the planar, that's how it looked. And then in the follow-up study, which we saw some activity, it turned out that this activity from the heart, but if you're looking from posteriorly, that's what you're seeing here. But the same area which was metabolically active, indicative of disease, now there's no evidence of disease. But you need the CT for that. But it takes more time and more effort if the CT is not done at the same time and at your fingertips. Similar study where a patient had right tonsillar swelling, had tonsillectomy, and pathology showed paraganglioma, and M.wmv showed left paravertebral lesion, which is, this is anterior view, this is liver, here's you're looking posteriorly, so this is liver, this is heart, and you have very intensely added area in the posterior mediastinum, posterior paravertebral area that's very difficult by the planar, no matter what you do, to try to come up with localization. So again, we actually call this area, because we were under the gun to release the food, which is very common in the state that we'll always have to release the report to the same day. So we released it, but we put a disclaimer that we don't know, and we will add an addendum once we have the CT available. Sure enough, we get the CT, and here's the area now. Again, looking at the SPECT, you don't know where you are, but then you look at the SPECT CT, and you see that this is actually a normal physiologic uptake in the kidneys. So, and the area in the adrenal, which is the area of concern, at that time was totally negative. So change the read from definitely positive to definitely negative, but without having the CT, there is no way of telling. Here's another case in a patient who had liver mass, suspicious for metastasis on the CT in an octave scan. And again, looking on the SPECT area, you see mild activity, but it's very difficult to tell. But when you have the CT and a very convincingly an ugly looking mass on the CT, and then you fuse it with the SPECT of the octave scan, you come up with multiple liver lesions. So we were able to systematically collect some of these cases and make a case to the hospital, which is not uncommon in the U.S. that I work for the university, but the hospital is owned by a different entity. In my case, it's Tenet, which owns about 150 some hospitals in the U.S. So you have to make a case for them, and trust me, it's an uphill battle because there's no money in it, because the charge is the same for the SPECT CT as it is for the SPECT. And you're not going to be able to do more patients. It's very difficult to convince hospitals. It's much easier in the PET world. So this happened to be a product of Philips. It's the XCT, SPECT CT. And as I always said, in the PET CT world, there is no bad PET CT. These are excellent scanners. Vendors of the world are pouring millions and millions of dollars in research and development to come up with the best scanners that they can. So by no means I'm favoring one over the other. The one that we have happened to be an XCT, and I'll show you what are some of the unique features that we are using it for our benefits, but just keep in mind that other vendors have also superb SPECT CT technology that's very comparable. It's what you're going to be using it for, what patient population, what studies may make one scanner better for your settings than another. So these are kind of a list of summary of the advantage of that particular system that you can acquire. High resolution, and I'll explain to you what's this all about. Larger bore gantry to accommodate our ever-growing patients, and we talked about this. Flat panel technology, we'll talk about this, but basically you control the amount of radiation dose that you're giving to the patient, and then also full patient flexibility for patient positioning and types, and full iterative technology, Astonish imaging, we'll talk a little bit about that, and the small footprint, that's one crucial advantage for this particular scanner. For us, where I work, is that we needed a scanner that we can basically get the SPECT, put the SPECT CT without having to tear down any walls. And that was important, that you have the same footprint that you have for the SPECT. So in cardiology, one of the advantages of the system is that you can acquire CT either by slowing down the system and acquiring the CT over 60 seconds. You are intentionally blurring the CT information at the expense of the CT detailed information, but with the advantage of having the CT matching the SPECT, so that way you will have less misregistration between the SPECT and the CT, because that is the problem in the misregistration in the PET world and the classic SPECT CT scanner, is that the SPECT is slow and the CT is fast, so you may have misregistration as a result of that. And then also you can acquire just one single field of view, which is 14 centimeter. If you position the heart appropriately, then that's all you need to include the heart. You don't need to image above or below that. Now, this has been published a long time ago, making a case that the use of attenuation correction is the current recommendation by the ESNMS. This was back in 2004. And the reason for it is that it increases the specificity of myocardial perfusion imaging. And that's why. This is from our scanner, where if you have no AC, which is the top, versus CT AC at the bottom, here you have what looks like inferior wall defect, and we all have seen that in nuclear cardiology. But then if you use the CT AC, which you get rid of this inferior diaphragmatic attenuation problem, now you see that it's normal. The inferior wall is absolutely normal. So this study, you'll call it, I'm not sure, or maybe you will overcall it as an inferior wall defect, but in the CTEC we call it absolutely normal. And now, whenever we do CT for attenuation correction, we'll look at the study with and without, and I'll explain to you why. This is a problem, and that's actually why we have to look at both. In some scanners, and we see less of that. I work at another institution in St. Louis, and they have another scanner by another vendor, and I've seen this more commonly, where you have artifacts, especially anterior anteroapical defect, that you look at the CTEC, you'll see it, but you look at the non-EC, you don't. And that's why we have to look at both studies, because there's some artifacts, especially the inferior wall, that you see it if you don't use attenuation correction, and it disappears when you use CT for attenuation correction. But then you have some artifacts that if you use CT for attenuation correction, you'll see it, such as the anterior anteroapical, so you have to look at the non-EC. If you look at the non-EC, it will go away. So kind of there's some defects that appears or disappears based on the type of attenuation correction that you use. So you have to get to know the capability of your scanner and what kind of artifacts that may be introduced in that particular image acquisition. But the assumption is that if you use CT in the SPECT CT for cardiac imaging, it will change testing algorithms, and then you can have incidental non-cardiac findings. Now I'll show you an example. This is a 78-year-old male, hypertension, diabetes, and presenting with chest pain. Just for the interest of time, I'm not going to be asking questions. I think we're going to have a session, more interactive session with questions and answers at some point in time. But if you look at the reprojection images here, you'll see that there's some artifacts. This is the heart, this is the liver, but there's something here. So this can be multiple things. It can be in the right atrium if there is right atrial enlargement. It can be a lung lesion because this is a MIBI. That this could be a lung tumor. If it's anterior, it could be in the breast. If this is a breast cancer, so there are a long list of differential. And without having the CT, it will be impossible because if you look at the cardiac, it's actually negative. So it's not a cardiac-related issue, but then it's a hunt of what is that. But if you look at the CT, you'll see that there's a huge hiatal hernia, and that is what you're looking at. So this is actually a part of the valve that is protruding up on the right of the heart, and that's where we saw it in the projection images. This is just to touch base on Astonish, which is all vendors have their own software that will enable you to do some iterative reconstruction with which you can have either half-time image acquisition or half-dose injections. I'm aware that GE and Siemens have their own software because, again, what we have is the Philips. So what they have is Astonish. So we did a study. We presented it at the European meeting in Vienna a couple of years ago about that particular software. So if you look to your left, this is the full-time image acquisition without Astonish, and on your right, that's half-time with Astonish. And you can see that we basically took a bunch of studies, We have two physicians, board certified nuclear medicine physician, reading them blindly, not knowing which one is half and which one is full-time image acquisition. So the full was your normal cardiac studies, the half was with Astonish, just to see if Astonish's half-time image acquisition is just as good as the full-time acquisition without Astonish, and the answer is yes. So I'm showing you three examples that both studies were reported by the reading physician as normal, but you can see that the one on the right looks crispier, and that's the advantage of this iterative reconstruction. If you look at this study, where again on the left is full-time and on the right half-time with Astonish, both were reported as mild ischemia in the anteroseptal and lateral walls. And here is the third and last example, where the full-time on the left, the half-time with Astonish on the right, both studies were read and reported as inferior wall infarct, which you see in both. But you can see how crispier, cleaner the images on the right with the half-time. And since then, that is our standard of care. That is what we do to the image acquisition. As a result of using the Astonish, is cut by half. I can tell you from my own personal experience, you can do half dose, but only in cardiac. You cannot do this in bone scan because I tried it and it did not work. As far as oncology, if you look at this plot, most of us working in this group, so it would be nice to use the kind of CT that would be helpful in the localization without having to go into the diagnostic range of the CT dose, because we want to present ourselves as less radiation dose, or at least as low as reasonably achievable. So I'll show you a couple of examples. 57-year-old female neuroendocrine tumor from the liver mass that was biopsy proven in January of 2012. This is the FDG PET scan, and you can see that there is nothing impressive in the FDG PET study at all. And if you look in the transaxial cuts, the arrow is pointing to the abnormality that you can see in the liver window. But in the FDG, there is mild heterogeneity at best in these areas. And if I'm looking at the PET alone, I wouldn't be calling this necessarily abnormal. We all know that because of the OSEM reconstruction, that you can have heterogeneity inherent to the liver. And so you have to avoid overcalling things in the liver. So these are all known liver lesions with minimal heterogeneity on the PET side of things. Here's the octave scan, definitively, unequivocally showing liver lesions. And actually here when you look at, this is the CT from the SPECT CT in the XCT scanner, and you see the exact localization of the liver lesions. And in fact, here is another lesion in the left lobe, and we saw even subtle lesions that were not picked by the original contrast CT scan of that patient. There's another case of 76-year-old male with gastric serous papillary carcinoma, had chemotherapy and surgical resection from the right flank soft tissue mass, and had positive mesenteric lymph nodes that were consistent with metastatic carcinoid tumor. Here is the octave scan showing some abnormality. Again, in the right abdomen, without having the CT, it will be difficult to localize this, and it could be a normal physiologic bowel uptake, but having the CT information is fusing into what appears to be a mass on the CT. So it makes reading scans a lot easier when you have CT right there at the finger of your tips. 47-year-old male presenting with newly diagnosed left neck melanoma, had excisional biopsy. So this is the lymphoscintigraphy of the scan. We all have seen cases like that where you see a big blob from the injection site, and you hope that the sentinel node is not behind this blob, otherwise you're not going to see it. So it's a little bit lower to that lesion, but again, the exact localization is very challenging in this case. Here is with the posterior transmission, which is the standard way of trying to get some anatomic information about the location of that sentinel node. Again, a big blob and a smaller blob. You turn on the light, and here not only you can see exactly where these lesions, but you're going to learn that these are actually two nodes and not just one. Again, if you look back at the planar images, there's no way that anyone would be reading this as two nodes that both appeared at the same time of the injection. So both should be marked and both should be sampled intraoperatively, and that was the case. This is a 78-year-old female presenting with hypercalcemia and a PTH level of 479, which is markedly abnormal. So as we all have seen cases like that, it lines up in the posterior to the right thyroid lobe, consistent with an active parathyroid adenoma. In this case, the CT is helpful in showing you where, but you could have made a good guess based on the planar images. But here's another example, which is a little bit different scenario. 64-year-old male, hypercalcemia, and a parathyroid hormone of a 195, markedly abnormal. And you can look at the planar images here. These are salivary glands. Here's thyroid, and there's something that's very faint. If you look at the planar, it's really very difficult to call a lesion like that as abnormal. And if you look in the SPECT images, this is the challenge in the SPECT. Frequently, when you do SPECT images, it's actually more confusing because it's giving you tomographic information, but then at the same time, the planar, you still see dimension, you still see how close or how far it is from the thyroid this time. But it's, and you do the SPECT, and it's a blob, but you don't know where this blob is. But then you see this one, where it's very interesting because these are the thyroid, and then posterior to it, and if you look here, there is about 4 millimeter lesion, and this is how these scanners are good now in seeing these smaller lesions. That is actually not just posterior to the thyroid, but we described it as being parathyroid adenoma in the paraesophageal region. And the surgeon really appreciated that because it makes a difference in how they would approach it surgically. As far as orthopedics, and I think that's the very exciting part of the type of scanner that we have, it has this high resolution capability, and I'll show you how that can be very helpful. We're all familiar with this kind of bone scanning, and this is what comes to mind whenever you think of bone scanning. Your eyes are looking for areas of abnormality. That's easy enough in a male. That you'd say based on this pattern, this is a super scan, and this is in a male, probably going to be prostate, and sure enough, that was the biopsy proven. Well, that's easy enough, and it takes about 10 seconds to read a scan like that. But then you have a case with HCC, status post orthotopic liver transplant. This is not live, I'm sorry about the typo. And then you do the whole body scanning, and you see that there's some fecality here. Now, this could be in the skull, could be in the brain, could be in the skin. There's no way of telling. You do the CT information, and you see the perfect fusion that this is fusing into what appears to be a living lesion in the posterior left skull. So this is the nice thing about the CT. I'm building a case for the how the high contrast, high resolution images will make a difference. This patient had a history of hepatic adenoma and persistent elevated alkaline phosphatase since October. This is obviously wrong, 2011. No history of previous fracture or trauma. You do the whole body scanning, and you see some fecality, distal aspect of the left femur. So the differential in this case can be many things. It could be bone infarction, it could be inchondroma, it could be isolated bone metastasis giving the alkaline phosphatase level. It could be also fracture or trauma, even though the patient had denied that. You do the SPECT CT, and you see that this is actually intramedullary here, and there's some calcification going on. This is so far what would be labeled as normal SPECT CT, but then you look at the high resolution images, which goes down to 0.3 millimeter. So that's how low the thinness of the cuts that we have, and you can change the whole read and say, I am seeing stipple calcification within the distal femoral intramedullary cavity without additional aggressive features. This is consistent with inchondroma, and they are not familiar, the ordering physicians, with our CT capabilities, so they still order the X-ray. and they read it exactly the same. But you can see that the X-ray in this case would not be adding anything, and in fact this is a much better, more detailed, high-resolution images than the planar X-ray. So in some of these cases, or in most of these cases, you are definitely eliminating another test. So just like skull lesion, we wouldn't be ordering X-ray for further evaluation. In this case, we didn't order X-ray for further evaluation. However, they went ahead and ordered the X-ray anyway. Here's another case of a 16-year-old female with complaints of pain in the right foot, lower back, right hand, left ankle, history of recurrent cellulitis of the right foot. Most recent episodes of active osteomyelitis was diagnosed in the right fourth toe and had antibiotic therapy for that. The reason why the study was ordered was to evaluate for multifocal osteomyelitis because the patient had long history, long problems, and they wanted to see if there are other sources of osteomyelitis that are more problematic than the toe. The patient before the bone scan had an MRI, and the MRI was read as osteomyelitis of the fourth proximal phalanx and cellulitis, as well as having an X-ray which was read as totally negative. So the bone scan, here's the bone scan, which was ordered again, as I said, after the MRI and the X-ray. You can see that there is some focality here. These are the planar images that we're all used to, and if you are good in reading, you may be able to guess the exact location of this, but that's about it. And if you are not busy, then you may say, you know, we should have done the three-phase, which we did. Apologize, this may not be projecting well in the monitor. It looks better in the computer. But just take my word for it that you have a little bit of increased flow in the region of that same toe that was seen as abnormal on the MRI. You do the delayed images, and again, that will be the classic three-phase as well as a whole body scan, and you can stop there. If you have SPEC capability, again, it gives you nice, impressive rotating images, but it does not add anything to what you already learned from the three-phase bone scan, right? Then you can do a SPEC CT, and you can add to the localization of this. I had a senior radiology resident reading the scan with me, and he was very impressed because when we did the high-res image acquisition, he was impressed because we were able to point to a fracture as well as a bone fragment that were not known and were not seen. The X-ray was read as totally negative, and it was not seen in the MRI. So now you're getting into a level of the high-resolution skeletal scintigraphy that is giving more information than ever before. And I joked with the resident that after all these years, I'm going to have to go back and learn all the names of the little bones of the feet, which I always forget. Because of the resolution of the images, you can no longer say second, fourth toe. They are expecting you to give more detail. And I'll share with you some images or some studies that are not mine, but were sent to me through some colleagues. This study is from Sydney, Australia. An 11-year-old female fall with left ankle inversion 5 days ago, pain on the weight bearing. SPEC CT showed left distal fibular growth plate fracture, which you see it here. You can just see subtle asymmetry between the right and the left, but it's very convincing when you look at the high resolution images. So it gets into the definitive localization of that fibular injury to the growth plate. Here's another study from Australia also where you can see how exquisite the information that you're getting from the high-resolution SPEC CT images in the left foot pain scenario where a patient has stress fracture in the distal left second metatarsal bone. So in this case, SPEC CT confirmed the exact location of the fracture and showed the callus formation. I don't know if you can see it from where you are or not, indicative of the repair healing process. This kind of information we never had access to in reading bone scanning ever before. Here's another case, again from Australia, where there's right foot pain, no history of trauma. The SPEC CT showed a fracture in the distal right fourth toe, which you see it in the arrows here and here. So SPEC CT confirmed the exact location of the fracture, clearly seen in this high resolution that goes down to 0.33 millimeter. This is one of my favorite cases, again from Australia, where it's right breast pain, SPECT-CT showed a fracture in the right scaphoid bone and contusion of the right DNA. So again, that confirmed the exact location, but these are the kind of SPECT-CT information that you're going to be seeing. So we better be prepared for that. Infection, clearly we do a lot of imaging, but the problem is gallium and indium both are kind of dirty looking image acquisitions. So having a CT and having the capability to do the isotropic voxels where you can have slice and dice, because it instead of taking things in transaxial cuts and then constructing from it volumetric, it actually works in the other way around. You get volumetric image acquisition, then you slice it and dice it in any views that you want, and you're maintaining the resolution in the coronal sagittal transaxial cuts, which is unique for the new SPECT-CT technology. This is a gallium scan in a 77-year-old female. You can see how difficult to localize things on the gallium, but you can see in the SPECT-CT how exquisite the localization to that disc and the disc space as well, the L5-S1 abnormality. Here's one of our cases in a 42-year-old female with bacteremia and renal disease. Patient was in hemodialysis and had AV fistula in the left distal arm. You do the planar images, and you see here's liver, here's spleen, normal distribution of the indium white blood cell scan, and you see some focality here. We were not aware of where exactly the injection site, but we knew that this was close enough for the AV fistula site, so it became the suspicious. But then you take that suspicion and make it definitive by doing the SPECT-CT. It's not a skin, it is inside, and it's fusing into the exact location of the AV fistula. Patient had an ultrasound that showed a hematoma surrounding a patent dialysis access graft, was sent to the OR, and it was confirmed as a 4-centimeter fluid collection, and the microbiology culture showed staphylococcal infection, confirming it. Here's another case of fever of unknown origin in a TEC 99 M1 blood cell scan. Study showing increased uptake in the sigmoid colon. You can see the challenge in localizing something like that, and this is not a clear, clean CT, but it's good enough in the localization of that abnormality that you're looking at it in the multiple cuts and saying, this is not a bone abnormality, this is an actual infection process, and based on this study, the patient started antibiotic. I like this study. Again, it's not mine. This is actually out of the university, our colleagues in the University Hospital Case Medical Center in Cleveland. And if you look at the top, this is an FDG PET-CT that showed an abnormality in the form of this increased focal uptake in the spine, and probably at level of L4. And when you do the sulfur colloid and you do SPECT-CT image acquisition, and you look at where the crosshair is, cross line is, you'll see that there's actually a cold area in that location. So it changed the read completely. What's on the top is the CT of the PET-CT. What's at the bottom is the CT of the SPECT-CT. So even though it's a significantly lower radiation dose, you would agree that the quality of the images is comparable, and in fact, it may be arguable that this may be even better quality images. And this was a state-of-the-art PET-CT against state-of-the-art SPECT-CT. PE, we all know that we have strong competition from the CT, and it's always an ongoing problems, whether or discussion whether to do CT for PE or to do VQ scan. And I think SPECT-CT is giving us a unique opportunity to end this discussion once and for all. Part of the problem is that we can give a differential about a mismatch or a match, but the lack of anatomic information makes it difficult not to have another follow-up image acquisition, which could be the chest X-ray or a CT. And we know chest X-ray is not great, and we know also that frequently these patients are sent to have the VQ scan without the chest X-ray, And in the old school, it used to be that you need to have the chest X-ray according to PET, so you hold the report, you don't declare it until you have the chest X-ray. Now, when you have the CT information, not only you don't need the X-ray, but you're getting information, as is the case here, where you can have a loculated pleural effusion as the cause of a mismatched perfusion ventilation defect that we're giving the CT information. For the longest time, the argument in doing the CT for PE is that you're gaining a lot of anatomic information that you don't have in the DQ scan, but now we can take this argument out. So, our experience with that particular scanner at SLU, which is St. Louis University, that it helps in the registration without having to deal with a bit index, that we like the flexible breathing where you can do image acquisition with a breath hold that's 12 seconds, or you can have tidal breathing over 60 seconds to decrease the abnormalities of misfeeding, and that comes in handy in the cardiac. The high resolution showed you some examples of how these high resolutions can be very critical in skeletal scintigraphy in particular, that we never reached that level of details in reaching to the 0.33 millimeter. The workflow we like it because we did not need to have lining of the walls. We did not have to increase the size of the room because the footprint is the same, identical to the Bright View SPECT scanner. And then we also did not need to have additional shielded area for our technologists because they can operate this the same way they're operating a SPECT scanner, giving the amount of radiation dose. One unique thing that we have in our scanner is also the imaging environment. We have the ambient imaging environment, which is one of the things that we always forget is how stressful patients when they're coming to have our study. And it's important for nuclear medicine, more important than CT, to have a more patient-friendly because of the length of the exam. If someone is going into a kind of difficult environment and not patient-friendly and having a CT that will be finished in 30 seconds, it doesn't really make a difference. But if someone is going to have a study that's going to take a good hour, then we need to do a better job in making it more patient-friendly. So we have some unique features where you can have the child can pick whatever scene that they want or theme that they want, and we control the lighting of the room, the decoration of the room, the kind of music, how someone wanted open spaces, more relaxing, wanted to look at view from Australia, we have that. A child that wants something child-friendly, such as this one, we have that, and I can tell you it made a big difference in the pediatric population. So I work at St. Louis University, as I said, in the Midwest. We have a lot of competition. We have a lot of SPECT CT scanner. We have Barnes, Washington University. We have extensive medical centers with high-end scanners. So it was very important to get some uniqueness in our SPECT CT scanner in order to compete with them. And that's a healthy competition, as well as position us in participating in some clinical trial. This is a very exciting new trial that we will be starting in May, where we're comparing FDG, PET-CT, high-end PET-CT scanner to technetium-99 labeled with an FDG equivalent, which is something called ECG, on the SPECT-CT scanner in patients with lung cancer. The idea is that in remote areas where they don't have access to PET scanner, you can have them undergo this study, which is technetium-based, and if it lights up, then you can send them to biopsy directly. If it's equivocal, you can send them to have an FDG PET, but if it is negative, then you don't need to send them to have a PET scanner because that means it's not cancer. And the earlier phase 2 showed that actually it does not light up when there is infection with granulomatous disease, so it's arguable that it may give good information, better even than FDG PET. Still, I don't want to oversell that, but it's certainly exciting and worth looking into it. And the phase 2 had compared PET-CT high-end to low-end SPECT-CT scanner, and I think that's why the results were not as good as, and now they are concentrating on leveling the field and comparing apples to apples by having a state-of-the-art PET-CT compared to a state-of-the-art SPECT-CT, and that's why we're participating in this. I thank you for your attention. I'll be happy to take any questions.